It's my great pleasure to welcome Dr. Stephen Hodgins to speak today. Dr. Hodgins received his medical degree from McGill University. He's a family physician by training. He also has an MSc, and I think if I was correct, residency, also at McGill, and a doctorate in preventative medicine and public health from UNC Chapel Hill in health behavior and public health leadership. He is an associate professor in the School of Public Health here at the University of Alberta, and he became interested in community health in low-income settings when he volunteered in India and has since then been working with First Nations and Inuit communities in Quebec. For the past 20 years, he's been working in global health, including extended periods living in Nepal, Zambia, and Washington, D.C. He's practice-based, but has a substantive involvement in applied research and is actually the editor-in-chief for the journal Global Health, Science and Practice. So welcome, Dr. Hodgins. I'm looking forward to your seminar.
Thanks, Joel. It's great to be meeting you all. I guess some of you I've probably met before, but probably many of you not. As Joel was mentioning, I come from a public health practice background with a focus on work in particularly sub-Saharan Africa and South Asia. I've been based here at the school as a member of the faculty for the last 3.5 years, but my relationship with the university dates back a little bit longer than that. I was, for a couple of years before that, I was serving on an external advisory council for the School of Public Health. But I'm a relatively newly minted full-time academic, having been here at the school just for 3.5 years. Again, that having been said, I'm still very much a kind of an engaged public health practitioner. And part of my role is kind of at the global level and also providing input at the country level on programs and strategies. So that's my background. And so it's good to kind of keep that take that into account as you're kind of hearing my comments. Now, the focus of public health, in distinction from clinical work, is that in public health, we're seeking better health outcomes at the level of whole populations rather than one by one. So I'll just backtrack here a little bit. So now that's not to say that doing work with whole populations is the only way to make an important contribution in healthcare. But for many of us who are working in public health, this orientation helps to keep us motivated. It helps us keep our eye on the prize, and it also helps us in weighing the utility of any particular activity we're involved with or that we're considering. So in global health then, our big preoccupation is achieving impact at scale. So impact at the level of whole populations. So, but how do we do that? How is improvement in health outcomes achieved at the scale of whole populations? There's a variety of, you could say, big strategies or stances. So first, as societies become richer, they tend to get healthier. So an important part of improving health outcomes for populations is growing economies and ensuring a more just distribution of the benefits of such growth. Now, it is worth noting that the causal arrow can also go the other way. So as Hans Rosling has shown, using the example of marked improvements in population health outcomes that were achieved in China during the 60s and 70s, and then that was followed in turn by rapid sustained economic growth. And those cases inform the idea of investing in human capital, areas like health and education, as a strategy for economic growth. Now, conceptually, living conditions also, it falls within the somewhat broader framework of the socio-political determinants of health. And as active, engaged citizens, indeed as global citizens, certainly there's much that we can do in this space. But for most of us as public health professionals, in our day jobs, our scope is a little more constrained. But in addition to advocacy work at the level of these broad determinants, more focused advocacy is part of our public health toolkit, both in a domestic Canadian context and in global health. And I should clarify here with this point that this kind of work really isn't instant. It can take an enormous amount of time and effort. But once you have a policy in place, at least in some instances, much of your work is done. Now, a good example of this work is work that was done on tobacco control here in Canada and in other countries, particularly over the last 2 decades of the 20th century. And in the end, this resulted in significant increases in taxes that reduced uptake by youth, and that's the kind of the entry point for smoking, restrictions on marketing and on smoking in public places, and accompanying influence changing cultural norms related to smoking. From this example, it's evident that even if we do get to the definitive step of putting in place a policy that can have society-wide consequences, typically it's a long, hard slog to get there. I mean, particularly when there are interested parties that have different motivations. Another more technical and less contested example of policy change resulting in improved population health outcomes is the adoption of a new vaccine into routine programs. But as with smoking, this can still be a heavy lift, marshaling the needed resources and, as necessary, building out the needed delivery infrastructure. And this is likely to be a major challenge over the next couple of years with deployment of COVID vaccines worldwide. So a third kind of way to think about it, kind of achieving impact at scale, is through strengthening health services and ensuring access. And I'm going to have more to say about this in a minute when I talk about MDGs and SDGs. And if you haven't heard about what those are, you'll find out about that in a minute. And finally, scaling up interventions. Now, as used in global health, the term interventions is most often used to describe technical biomedical inputs, things that can be administered by pills or by needle. But the term is also used for practices, both within health services, such as improved health worker hand washing, and by individuals and families in the community. So for example, safe sex practices, use of protected water sources, or in malarious areas, use of insecticide-treated bed mats. Now, in some cases, we have identified innovative interventions for which there may be big challenges with initial introduction and adoption. For others, it may be well-established, quote-unquote, interventions, but they're currently being used at quite a low level. So in some of the areas that I work in, one of the issues that we focus on is trying to increase kind of uptake of exclusive breastfeeding through 6 months of age. So in both of these cases, the task is to scale up or push up adoption and use to achieve high coverage. Now, as I'll be discussing in some detail today, much of the health-related efforts supported by technical and donor agencies, such as the World Health Organization, UNICEF, the World Bank, Gates Foundation, USAID, and other government donor agencies, such as Global Affairs Canada, have focused on this last area. And I'll be describing this to you as a disease control priorities perspective. Now, in global health, such a perspective has prevailed for many decades, but in its modern form, it can be traced to 2 seminal documents that were published by the World Bank in 1993. So the World Development Report, Investing in Health, which mainstreamed the notion of human capital, and the disease control priorities in developing countries, which created a small industry with other major products released in 2006 and then in 2018. I should point out this 2018 version of this came out in 9 separate volumes. And by the way, for those who are interested, the World Development Report and these 3 disease control priorities products are all available free online in electronic form. But to boil all of this down into a 1-minute elevator pitch, the idea is that important gains in population health outcomes can be achieved by focusing on the highest burden conditions. So a small number of causes that account for a large proportion of preventable morbidity and mortality. The most efficacious, cost-effective interventions for those conditions, and ensuring achievement of high effective coverage for those interventions, meaning that a high proportion of those needing the intervention get it delivered such that it can be expected to produce its intended benefit. Now, in the early 1990s, and the same is true today, though to a somewhat smaller degree, due in large part to the success of this strategy, deaths among infants and young children accounted for a big piece of preventable mortality and an even bigger piece of total years of life lost. 4 categories of disease and one very important contributing factor accounted for the majority of these deaths. Newborn conditions, notably prematurity, acute respiratory infections, diarrheal disease, and malaria, with the contributing factor being malnutrition. For each of these high burden conditions, there are a relatively small number of proven, efficacious, cost-effective interventions that can be deployed even in settings with very limited resources. Uptake and use of these interventions can be and is documented and tracked, and these measures of intervention coverage or use, along with tracking of mortality, allow us to monitor the effectiveness of our efforts addressing preventable early childhood deaths. Now, from the year 2000, as a framework for advocacy and as a means for monitoring performance, the Millennium Development Goals were developed, again with leadership from the World Bank. Now, in comparison with other fields, global health was especially well served by this framework, with 3 of the 8 MDGs specifically devoted to health. Reducing child mortality, MDG 4, improving maternal health, MDG 5, and combating HIV, AIDS, malaria, and other infectious diseases, MDG 6. Now, most, if not all, of the other 5 MDGs could be expected to have important, if less direct, impact on population health outcomes. With this advocacy and monitoring framework in hand, monitoring happened under the MDG Countdown Initiative. Through the MDG period ending in 2015, on nearly an annual basis, global reports and country-level fact sheets were released for 68 priority low and lower middle income countries that together accounted for 95% of the world's maternal and child deaths. Since most of these countries don't have vital registration systems that allow them to track mortality on an annual basis, Countdown monitoring focused on other measures, notably coverage for priority interventions, as reflected in this country fact sheet. But now we're well past 2015, and the current dominant development framework is the Sustainability Development Goals, with 2030 being the targeted date for achievement of the goals. Now, whereas last time there were 3 separate goals devoted to health, this time health has been collapsed into a single goal. Environment-related goals have expanded from 1 under the MDGs to 7 under the SDGs, and economic goals have expanded from 1 under the MDGs to 4. Now, there's a lot to be said for this more comprehensive conception of human development. It certainly better reflects a determinants of health understanding of the drivers of population health and well-being. You'll recall that living conditions is one of our big strategies for improving health outcomes at the scale of whole populations. And this framework directs more attention to the environment, which is certainly a good thing. Now let's look at a bit more granular level at how health is addressed under the SDGs. The specific language for this goal is to ensure healthy lives and promote well-being for all. And the associated targets are to end preventable deaths of newborns and children, and this corresponds to MDG 4, to reduce the global maternal mortality ratio, corresponding to MDG 5, to end the epidemics of AIDS, tuberculosis, malaria, and other communicable diseases, and that corresponds to MDG 6, And then the fourth one here is to ensure universal access to sexual and reproductive health care services. And this was grouped under MDG 5 in the earlier framework. So for the first 4 of these SDG target areas, for global health players, there's been substantial continuity from the MDG era, albeit with less prominent attention. So in this case now, we have 4 out of the 9 prioritized areas under 1 of the 18 SDGs, whereas under the MDGs, there were 3 of the 8 MDGs that were focused specifically on health. So, and then there's the following 5 SDG 3 targets addressing areas that were not included under the MDGs. To reduce mortality from non-communicable diseases, to strengthen the prevention and treatment of substance abuse, to reduce the number of deaths and injuries from road traffic accidents by half, to reduce the number of deaths and illnesses from hazardous chemicals and pollution, and then finally to achieve universal health coverage. So with these additional targets, several other areas responsible for a big chunk of global burden of disease now get greater prominence than before. Notably non-communicable diseases, substance abuse, road traffic accidents, and direct environmental threats to health. But practically speaking, the most consequential shift for health from the MDGs to the SDGs has been the new emphasis on what is labeled universal health coverage. Before looking at the details of what's implied by universal health coverage, it's important to note what this understanding of coverage doesn't include. You'll recall that an important element in what I've labeled the disease control priorities strategic stance is achievement of high coverage for specific interventions effective in reducing the burden of the most prominent causes of death, disease, and disability. So the focus is on what causes account for the biggest proportion of such outcomes. What are the most effective and most feasibly delivered interventions that can reduce the burden of such outcomes? And what proportion of those at risk are effectively reached by our prioritized interventions? With a disease control priorities lens, this is what's meant by coverage. In contrast, under the UHC framework, achieving UHC, universal health coverage, is understood to be a continuous process, making progress along 3 dimensions of coverage, all of which are concerned first and foremost with covering the costs of healthcare. The horizontal dimension refers to who gets their costs covered. So for example, in an American setting, if your employer doesn't provide health insurance, are you obliged to either pay directly for healthcare or to buy private health insurance? Or does the state in some way guarantee coverage of costs associated with your healthcare? The vertical dimension refers to how much of the costs of your healthcare you have to bear directly versus what's covered through collective funding mechanisms. Beyond what your insurance covers, what co-payments or deductibles are you responsible for? For the third dimension, for what specific services does insurance or some other collective mechanism cover the costs? In a Canadian context, if you need outpatient physiotherapy, is that covered under Medicare or under your employer-provided private health insurance, or do you have to pay out of pocket? Now, here what we're looking at is the contribution of these various funding sources to cover healthcare costs, comparing low-income and high-income countries. Now, it's true that in low and lower middle-income countries, out-of-pocket costs, uncovered services, which are shown in orange here, account for a considerably larger proportion of total healthcare expenditure than they do in richer countries. And publicly funded mechanisms, which are marked in blue in this figure, account for much less. It's also true that catastrophic health expenditure is one of the most important causes for families slipping into destitution in low and middle income countries. So it's a good thing to be directing more policy attention to the issues of financial barriers to access and the negative consequences of having a system in which healthcare costs are borne more heavily by individuals and families. But policy attention is a finite resource, and that includes attention from the likes of presidents, prime ministers, ministers of finance, and members of national planning commissions. Which brings me back to the title of my talk, Scaling Health Impact in low and middle income countries. So yes, it's a good thing for there to be public policy attention given to avoiding tipping people into destitution. But as a public health professional, my compass needle points to getting better health outcomes at the scale of whole populations. So much as I appreciate some of what we now see in the SDGs that wasn't included in the MDGs, I also worry about what I see as reduced attention to population health outcomes under the new framework. So for those of us who wake up every morning asking ourselves, how can we get health impact at scale in parts of the world with constrained financial resources, or stated a little differently, how can we get longer, healthier lives for whole populations in such settings? What do I think our strategic stance should be? So first, in large measure, I think we have been well served by the disease control priorities perspective. But to complement it, in my view, the movers and shakers at global and country level need to be addressing three other questions that have tended to be neglected. Who sets the priorities and chooses the interventions? What really gets prioritized? And how do we deliver these interventions? On the question of who sets the priorities, there was an enormous rise in funding in HIV, particularly for antiretroviral treatment services in low and middle income countries. And this began a little more than 15 years ago with the inception of US government funding under PEPFAR and the Global Fund, with its strategic direction largely determined by the major global level players. And there's no question that in countries with an enormous HIV burden, notably those in Southern and Eastern Africa, the decision to prioritize resources for HIV has been a huge benefit. Resources have aligned with proportionate disease burden for those countries. But as we see here, if we consider all countries receiving official development assistance funding for HIV, funding levels have not been aligned with either HIV burden or with financial need. In many countries, the offer from the global community has been, we have lots of money we can give you for health services, provided it's used for antiretroviral treatment. Now, as you can imagine, for decision makers in low-income countries with low HIV prevalence, this creates a certain tension. Of course, when resources are very constrained, any offer of new funding is attractive, but if HIV is pretty far down the list in your country for overall mortality, morbidity, and disability, and there's an offer of new funding, it's really a shame not to be able to direct those new resources where they're most needed. So in addition to dictating what health problems get prioritized for funding, donor agencies and normative technical bodies like WHO have also tended to dictate what interventions or strategies are used to address those health problems. Now, I don't have time to get into specific examples today, but in very many instances, those closer to the ground have a better sense of what's feasible and most likely to work than those sitting in Geneva or Washington or London or Seattle or Edmonton for that matter. Now, concerning what really gets prioritized, I've been making the case that priority setting should be driven by the question, what causes the greatest mortality, morbidity, and disability for which we have feasible, efficacious solutions? Now, during the MDG era and continuing under the SDG dispensation, most official development assistance for health, which remains a very important source of funds in low and lower middle income countries, most such assistance has been earmarked for one of a very small number of technical areas. HIV, along with a very small handful of other high burden infectious diseases, notably malaria and TB. Maternal child health, including immunization and certain nutrition related interventions, and reproductive health, including family planning. Now, as important as these areas are, at least for, for many low and middle income countries, there are other health issues that warrant equal, if not greater, priority. Now let's take a look at this data visualization from the Institute of Health Metrics and Evaluation in Seattle. Now what this shows is the relative contribution of all categories of health condition to total disability adjusted life years lost. And this is a measure that combines mortality, morbidity, and disability. This figure is populated with data from all countries classified by the World Bank as lower middle income. And this includes big countries like India, Indonesia, Pakistan, and Nigeria, but not countries such as the Democratic Republic of Congo, which is classified as a low-income country. Now, as you see here, newborn causes account for a little over 10% of disability-adjusted life years lost. And there's another 10% from lower respiratory tract infections, diarrhea, and malaria. And these are largely among infants and young children. So it's still the case in such countries that these traditionally prioritized child health problems account for a pretty big chunk of total population disease burden. But consider maternal causes. This is an area which has been prioritized for official development assistance for health over the last 2 decades. But you see, in these countries, it accounts for less than 1% of total burden. Even restricting to females aged 15 to 49, maternal causes account for only 4% of total burden, total disease burden, and about 7.5% of deaths. By comparison, among women in this age range, stroke and ischemic heart disease together account for 11% of deaths in these countries, and suicide accounts for 7%. And yet these areas receive almost no funding from official development assistance and relatively little program attention from governments in most low and lower middle income countries. Consider also the contribution of HIV/AIDS. As we see here in lower middle income countries, HIV accounts for just over 2% of disease burden and about the same proportion of total deaths. But close to 1/3 of official development assistance for health is earmarked for HIV. So moving now to my final point. Yes, it's a good thing that priority attention in global health has been given to the actual content of health services and programs, what we commonly refer to as interventions. And it's a good thing that we've been holding ourselves accountable, tracking coverage, that is, what proportion of those needing these interventions actually get them. But interventions don't deliver themselves. Certainly, low and middle income countries do invest their own resources to ensure that there's some kind of a health system to deliver services. Even in the poorest countries, generally almost all of the costs associated with staffing public sector health systems are assumed by the government, not by donors. But building strong systems and developing sound, context-appropriate delivery strategies has been a relatively neglected area. As long as it continues to be neglected, we won't do as good a job as we could be doing to ensure that efficacious interventions addressing high-burden health conditions get to a high proportion of those needing them. So this is where I'll leave you. Let's keep our eye on the compass needle, paying attention to what's contributing the most to total population health burden. But decision-making on priorities and approaches needs to be happening closer to the ground, not dictated from the global level. Let's be flexible, focusing our attention where the data tells us there's the greatest need. And if we're serious about making sure that our interventions get to those needing them, we need to pay attention to delivery, meaning the systems doing the work and the approaches used in making services accessible to those needing them. Thank you.